and greetings to one and all. My name is Rekha Singh. I will be hosting today's webinar on management of hypoalbuminemia in COVID cases. Plasmagen Biosciences is a responsible biopharmaceutical company enriched with more than a decade of experience in providing world-class plasma-derived medicinal products and is based out of Bangalore. We envisage in providing immunological medicines worldwide, which provides relief and longevity to the patients suffering from life-threatening diseases. It is a glorious moment to extend my warm wishes on behalf of Plasmagen Biosciences. I want to convey my heartfelt gratitude to Dr. Shushruth Bandyopadhyay, Dr. P.B. Nagagopal, Dr. Rajesh Chandra Mishra, Dr. Sachin Gupta for accepting our invitation and presiding over this webinar. Now I would like to introduce our esteemed key panelists. Dr. Shushruth is a renowned intensivist who has more than 28 years of experience in critical care. He is currently working as a director of Department of Critical Care at AMRI Kolkata. He is a member of the Executive Committee of Indian Society of Critical Care. Dr. P.B. Nagagopal has an enriched experience of more than 37 years. He is working as a senior consultant and head in the Department of Critical Care Medicine at Continental Hospital, Hyderabad. He is an esteemed member of various associations like Infectious Control Committee, Quality Group, Society of Critical Care Medicine, European Society of Intensive Care Medicine, European Society of Clinical, Micro and Infectious Disease. Dr. Rajesh Mishra is currently working as a consultant intensivist and internist at Shabya Comprehensive Care Clinic, Ahmedabad. He is an inspiring focus leader in the field of critical care medicine in India and SAARC nations. He is currently the president-elect of Indian Society of Critical Care Medicine. He heads the Critical Society and a charitable registered trust, which helps in organizing educational programs and public awareness, educating underprivileged girls and offering free treatment to the poor patients. Dr. Sachin Gupta is currently working as a director of critical care at Narayana Health, Gurgaon. He has various professional memberships and certifications such as Indian Society of Critical Care Medicine, Society of Critical Care Medicine, World Interactive Network focused on clinical ultrasound, European Society of Intensive Care Medicine. He has won many prestigious awards such as Presidential Citation Award by Indian Society of Critical Care Medicine for outstanding contribution towards growth and progress of ISCCM. Fellow of Indian College Critical Care Medicine awarded by Indian College of Critical Care Medicine, Fellow of Critical Care Medicine awarded by American College of Critical Care Medicine, and many more. So now I would like to invite Dr. Shushruth and request him to embark the panel discussion, and delegates are requested to write their queries in Q&A section. Over to you, sir.
Thank you for the kind introduction. We're supposed to, I was requested to get a panel who would be not only esteemed, but also academically interested in discussing such a new topic. This is something new, and as I told you, the data are not much, but then it can be interesting. There's been relations pointed out that albumin does have some relations with COVID infections. And COVID infections, as we already know, that has been ravaging the world for last more than 2 years. And we have seen all sorts of, all of us were directly involved in managing COVID patients, and we have seen all sorts of complications and variations of COVID, at times with high mortality and complications. So can I have the first slide, please, Mr. Singh? Can we have a full screen?
Yes, doctor. Is my slide visible now?
Yeah.
Fine, doctor.
Next one. So this is introduction to COVID. I would go into that. We already have been handling COVID, and we diagnose it with right now with this mostly RT-PCR and also sometimes rapid antigen tests. And there are variants which have been coming. There are 2 big outbreaks in last 2 years, and right now we are going through the 3rd one. And there are some variations in the presentations which will come out in the discussions. Can we have the next slide, please? Missing, can I have the next slide, please? Yeah, and already as pointed out that COVID has got, several ramifications or several complications. It involves almost all the systems from neurologic to cardiac to the systemic, vascular, hematologic, and kidneys, although the main presentation remains respiratory, and all the COVID treatments have been directed towards respiratory complications, but people may have serious cardiac, systemic, neurological complications, and vascular complications. So that is the thing. And right now we'll be discussing something which has not been discussed much. That is, is there any relation to hypoalbuminemia in severe COVID patients? And does that have any clinical or therapeutic implications? Next slide, please. So this is the prevalence of hypoalbuminemia in COVID. So this is already we know the definition of hypoalbuminemia, that is 3.5 grams per 100 ml. That is the cutoff, and if it is below that, then we take it as a hypoalbuminemia. And some trials, this is one 3-hospital trial from Wuhan, China, and here about 50% of the patients they had hypoalbuminemia during admissions. They had older, they had a higher proportion of combined combined diabetes mellitus, fever, dyspnea, and natriuresis, and had relatively poorer prognosis than people with normal albumin. And the people with low albumin, they had also high levels of CRP, leukocytes, liver enzymes, total bilirubin, and LDH, creatine kinase, D-dimer globulin, and lower levels of lymphocytes and eosinophils. We know that COVID comes with all sorts of presentations, and some of these have been linked to the outcome in COVID, but whether actually they're cause or effect, or whether we can actually demarcate the COVID as serious or not so serious by these markers, we do not know. We know that COVID needs intervention when the COVID has got hypoxemia, and almost all the successful trials are dependent on that. But then these are the associate markers. Decreased albumin is correlated with adverse outcomes. Can we have the next slide, please? This I won't go into the details. This is a picture of then what happens in any systemic inflammatory response when the patient goes into uncontrolled sepsis. There is low albumin because of also both low production of albumin, because the resources are directed towards producing some more subjects which are more beneficial for sepsis, and also leakage of albumin through enhanced gap junctions of the capillaries, where the albumin goes to the third space, and there is a general low level of the serum albumin. And this is has got severe implications. These are actually theories that this might give rise to intervention. Sorry, this might give rise to complications like the following. Can we have the next slide, please? The physiological function of albumin is provides oncotic pressure, binding and transporting substances, and maintaining acid-base equilibrium. This is the main one of the main factors which maintains the acid-base equilibrium, perhaps the main thing which maintains our acid balance. And during critical illnesses, inflammatory mediators decrease albumin synthesis. Additionally, these mediators increase vascular permeability, which I've already discussed. And albumin oxidation and breakdown affect interaction with the bioactive lipid mediators that play important roles in antimicrobial defense and repair. So whether this low albumin actually makes the body more susceptible to the secondary infections or sepsis, or basically albumin is just an innocent sign that the patient has got a severe cycle of sepsis, we do not know yet. And hypoalbuminemia also predicts the development of healthcare-associated infections, particularly Clostridium difficile. Next slide, please. It also is related to antimicrobial treatment failure. I'll wait here. I'm interrupting the slideshow. I'd ask the panelists right now to tell their opinions about what they feel is the role of albumin, or what is the benefits of checking albumin or trying to increase the albumin levels by transfusion or other means in any patients with acute inflammation. That is, might be sepsis, that might be COVID, that might be viral infections or trauma, maybe whatever it is. Let's start with Dr. Gopal. Dr. Gopal, please.
Thank you, Dr. Bandyopadhyay. Albumin, as you very correctly said, has been a very intriguing molecule ever since it was manufactured as a therapeutic agent. And we have seen the scientific literature and the evidence yo-yoing back and forth to the point that in 1996, it was said that the mortality rate actually increases if you give albumin to septic patients. And today, we are also seeing in the surveying sepsis guidelines, if you use albumin in the initial stages of resuscitation, it may actually benefit the patient. So the up and down of literature has been for a simple user like me has been very confusing. But as I was telling you offline, since we all use albumin in various conditions, various circumstances, I always felt that we need to know more about albumin. And then, of course, COVID came in. The role of albumin in various stages of sepsis resuscitation, multi-organ failure, and ARDS especially is controversial. Nobody can say with emphatic evidence that it does benefit or it does harm. So it's the evidence is a bit equivocal, and it depends upon how you read the literature and how your personal experience with albumin has been. Having said that, in this last almost 2 years now, COVID has hit us in India, especially in March 2020, and we are in January 2022, 22 months almost. We have extensively used albumin in COVID patients in various circumstances. As you would show in the coming slides, and you would have already shown a bit, the study from Wuhan, I'm going to throw a few slides later with your permission. There seems to be a good relationship of albumin status at the time of presentation in a COVID patient. And we have seen this in general sepsis also, that hypoalbuminemic patients, when present in general sepsis with MOD, SMOC, and related complications, fare worse. Not only that, going forward, with therapy or without therapy, the drift of albumin also seems to be a prognostic indicator. Why and how is a matter of prolonged discussion. I would request you to invite the opinions of my other colleagues at this point.
And now I ask Dr. Gupta. So already told by, as Dr. pointed out by Dr. Gopal, that albumin is basically, the balance is sometimes lost with the patients with sepsis and other severe inflammation, systemic inflammations. So as you have been treating a large number of patients, I gather you have a large bed strength. So as a intensivist, when actually you look into albumin, what is the value which triggers you to do something? What do you do at that point of time? And what do you feel the results are?
Thank you, Dr. Sushruth. So, see, frankly speaking, I have looked albumin as an acute phase reactant when it comes to COVID. Patients who are presenting with high numbers of other, inflammatory markers in terms of CRP or IL-6, D-dimer, ferritin, we have seen that the albumin levels are very low to start with, and this has nothing to do with their background diseases as in any other comorbidities. Only if I am talking about COVID per se, patients presenting with higher inflammatory markers also had hypoalbuminemia. Now, when you're talking about initial fluid resuscitation, yes, I have used albumin a lot for initial fluid resuscitation, because we felt that if you're not using albumin as a resuscitation fluid, I'm not using albumin to correct a number. I'm not trying to achieve a 3 grams per liter number of an albumin value, but I'm using albumin as a resuscitation fluid, as a major colloid use, because these patients had a huge amount of capillary leak syndrome. So they were much fast. They were not behaving like typical ARDS, a bacterial ARDS, where, by day 3, you started feeling that their lungs are getting wet. They were getting wet within first 24 hours if you are overzealously giving a lot of crystalloids. So I did use albumin as a colloid in initial resuscitation fluid.
Just one interruption.
Yeah.
You are using resuscitation fluid 20% albumin, or you are using this lower 4% albumin?
So it's a mixture. So initial, we used to give 20% over 5 hours, and sometimes we used to, put it in a 500 ml at 20% albumin and continuing over 100 ml per hour. So it was a mix of 20% versus, whatever you call that is 4% or 3.5%. But I would say almost 30 to 40% fluid was by albumin. And we realized, which was not the case in the first wave, very frankly speaking, we were totally that albumin has to be given on specific indications. Let us use crystalloids, what the common teaching says. And we found that we were overloading these patients. They were becoming more and more hypoxemic. Fluid overload was a scenario. And we tried to change the practice. And we found that it's an acute phase reactant. If the numbers are bad, don't try to correct them, but use this as a resuscitation fluid. This was my take looking at the second wave.
Thank you. And next we go to Dr. Mishra. Dr. Mishra always wants innovative ideas, and he always does not conform to these conventions. And that's why I asked him that, would you like to tell us few of your experiences where you have used this albumin supplementation, or say by you have diagnosed something new with the albumin level, some interesting cases which you have found in last 2 years, maybe related to COVID, maybe related to sepsis. Dr. Mishra, please.
So, sir, about COVID, it has really shown a like what you say, as a path that we have to investigate our patient like in broad way. And when it came to severe COVID, we had all kind of inflammatory markers which were very high. So one of the reasons what I found that irrespective when you do total protein, even if patient is like severe or critical, the even total protein is normal or higher side, but you will find globulin is going up very high because it's on the inflammatory marker. And to compensate, many time albumin, so many time we will see the total protein was high, but albumin was definitely low. Most of the time it was in range of around 2.7 to 3.2 until unless patient was critical, and when they were developing kind of going in shock, going in further progression in MODS, but not. Coming to the replacement for albumin, I mean, if we start looking for the evidence, probably we will not find any. I fully agree that hypoalbuminemia is one of the markers that, as I said, that level were definitely lower in the patient who were critical or who were in shock. Their level was going at below 1.5 or something like that. But somewhere total protein was being maintained or on higher side because the other pathway was getting activated where globulin was going very high in this patient as a part of inflammatory marker. Did I replace albumin as a theoretically that to giving less fluid or to maintain oncotic pressure or something like that? So I will say I did not, because I only did when patient has shock. If patient was not in shock, we were restricting all kind of fluid. We were kind of trying to find different pathway where we avoid giving any intra, because what Sachin is saying that it is a case of massive capillary leak. And one of the thought which I have, though I little bit different from what Sachin said, but he is also right in his place, that when there is a capillary leak, albumin is one molecule which also leaks. So if you give too much of the pressure, fluid which has high oncotic pressure, it will further increase that process. So only way to handle this process is trying to reduce the leak, try to reduce inflammation, trying to treat the primary pathology and not doing extra harm. So albumin we did use when patient had shock. Albumin we are developing MODS. We did not give albumin just to build up the albumin level, but total protein level was very high with inverse ratio. So that was the finding in COVID. That's what my thought is.
Thank you. Before we proceed to our next set of slides, I'd request Dr. Gopal. He has done some research on the pathophysiology of hypoalbuminemia in COVID patients. That's what I think you are going to tell. So can we have those slides, Dr. Gopal?
Can I share my
screen,
please. Dr. Bandyopadhyay?
Yeah, I'm not sharing, Ms. Singh.
I know, I'm sharing. Ms. Rekha, would you come up the share? I will share my screen.
Yeah, please stop sharing and so that, yeah.
Well, ever since this concept of basically Glycocalyx came in, I started hearing about Glycocalyx in a serious way around 2010. I have developed some interest in looking up to what is the role of Glycocalyx, and now even the students of critical care know that Glycocalyx is a very important part of sepsis pathology, and COVID is nothing but viral sepsis. And we also have realized, as our knowledge grew into the COVID etiopathogenesis and biopathology, that COVID is basically a endothelitis or endothelial dysfunction. And endothelium and vascular glycocalyx, endothelial glycocalyx, go together. And when these two organs get disrupted, any organ in the body can get affected. And I also developed this understanding that because the COVID route of entry is through lungs, it presents as pneumonia, but it can affect any organ, as we all of us know now. So this dysfunction has suggested, as if you look at the basic structure of glycocalyx, albumin plays a role in it. It's a dead structure. Glycocalyx is not a living structure. Endothelium is a living structure. But if glycocalyx gets spoiled, endothelium also gets spoiled, and endothelial leak and capillary leak starts. This has proved many times in majority of experiments, both in animals and in human beings. But one thing that is not proved to date is whether supplementing albumin will repair the damaged glycocalyx or not. This is not proved in human or even septic animal experiments. But slowly, as we are proceeding forward, pushed forward by research in COVID area, a few things came up which I had the opportunity to read up in the last few months. As we all know, vascular endothelial glycocalyx damage in COVID-19, basically, if you look at the last but one function, COVID-19 directly damages the vascular endothelial glycocalyx. And this is what leads to this syndrome called systemic inflammatory reactive microvascular endotheliopathy. Whether this endotheliopathy can be monitored and repaired by any agent is still a matter of research. These are the various things that SRIME can damage, accentuated by COVID attack. I won't go into the details, but this can actually lead to a strong inflammation, vascular endothelial damage leading to organ failure. This progressive SRME can be actually monitored by the byproducts of this endothelial damage, which is called VGX, which is vascular endothelial glycocalyx. Now, if you see in various studies, this thing has clearly come up that the albumin levels definitely have a correlation with the damage and the outcome of not only sepsis, but COVID also, which you have very elegantly proved in the first few slides. This is another one. If you see the serum albumin levels and the Murray score, as we proceed forward with various patients, the Murray score goes on increasing as the presentation albumin is low. Why am I telling all this? These are the mortality indicators of various measurable elements and clinical elements which are there in there. But what is more interesting is in these particular studies where the albumin versus, if you see this particular study, albumin versus crystalloid solution in patients with acute respiratory distress syndrome, in which they have seen that in ARDS, this was done in 2014. This meta-analysis has clearly shown that the relative risk of death is more if the albumin levels are low, and therapy with albumin solution improved the early oxygenation without affecting mortality. But this is not in COVID. This is in ARDS. Going forward, if you see the other studies where albumin downregulation and expression of ACE receptors, where if there is low albumin levels and the downregulation of expression of ACE receptors, which is the key element in COVID infections, is actually related to the FIA to PF ratio fractions of these COVID patients in relation with the albumin levels at the time of presentation. These researchers who have studied the clinical characteristics of COVID-19 patients have reported again and again that lower serum albumin levels are associated with increased risk of death, and they went ahead to suggest in these particular 3 studies that albumin therapy might be a potential remedy at the time of presentation. So going through these particular 3 or 4 slides, what I feel basically that the damaged endothelial surface and glycocalyx can be repaired by albumin, and this has been proved in some studies at the preliminary level, and there's a lot of research to be done in this particular area. This is the last slide. If you see, the SARS-CoV-2 bound human serum albumin and systemic septic shock. The septic shock caused by the COVID itself on the glycocalyx. You see the albumin being the central molecule here on the epithelial cells and endothelial glycocalyx. They concluded, this particular authors concluded, that albumin therapy to replace bound albumin or strategic addition of high sensitivity albumin to increase the overall concentration in fluid component delivery, as Dr. Mishra was telling, might elevate some symptoms, and Dr. Gupta also elucidated it, might elevate some symptoms leading to COVID. So with this brief presentation, what I want to say is that there is some relationship of the maintenance of glycocalyx. I'll stop sharing here. Maintenance of glycocalyx, the health of glycocalyx leading to endothelitis, endothelial disruption, especially in COVID, to the not only the presentation level of albumin, but albumin therapy at an appropriate time. I wouldn't be able to say, I'm not a scientist, I wouldn't be able to say at what time you should give it. Should it be given like Dr. Sachin Gupta gave in the second wave of COVID, or Dr. Mishra is elucidating to the reversal of the albumin globulin ratio? There is some connection there. So a lot of research has to be done in this area. Till then, what I personally feel, I had some cases where patients was almost looking at the very low PF ratio very early in the onset of COVID, both in first wave and second wave, and it would look like nothing but ECMO would save that patient. In 3 or 4 cases, when we actually gave albumin plus fusimate therapy to these patients and decongested their intravascular space by increasing oncotic pressures, I don't know where else albumin has worked, we could actually stave off that patient from ECMO and continue normal ventilation, and most of them could be weaned off also. But mind you, these patients we gave very early. I had at least 10 patients like that in this last 20-22 months, where very early in the presentation, the patient is rapidly deteriorating. We gave the combination of albumin and fusimate and could actually bring up PF ratios and could avoid further deterioration going on to ECMO or even mortality and morbidity. Thank you for letting me give this small opinion of mine. You are muted, Dr. Bandyopadhyay.
Thank you, Dr. Gopal. We remain enlightened. Ms. Singh, can you go back to our set of slides? Next slide, please. Yeah. So this is again, albumin has been related to an inadequate antimicrobial treatment, emergence of resistant strains, and basically what they're arguing is that many of the drugs, they get bound to the albumin, and the low albumin level might interfere with the PKPD of the drugs, and that might give rise to infections like Candida, vancomycin resistant enterococci, oxacillin resistant Staph aureus, and coagulase negative staphylococci. So can I have the next slide, please?
Just doing it, sir.
And it also shows that albumin has got some role in coagulation or coagulation. It remains a sort of anticoagulant. And it also is related to scavenging of tissue ischemia and free radicals, oxygen free radical scavenging. Albumin might be related to that. These are all theories, no direct clinical data coming from this, but they may have the patients with hypoalbuminemia may have a diminished immunological response, which may give rise to sepsis-associated complications like VTE, ARDS, and mortality. Albumin exhibits anticoagulant effects because of its capability to bind to antithrombin, like heparin, as well as its inhibitory effect on platelet aggregation. Consequently, hypoalbuminemia may be a contributing factor in high incidence of VTE. And there is again a big theory in COVID that possibly there might be microemboli occurring in COVID, which might give rise to this ARDS-like syndrome. Yet to be established, but then there is a strong proposition. And this hypoalbuminemia might be related to high incidence of VTE from 11 to 70% seen in COVID-19 patients. So in addition to prior known biomarkers like procalcitonin, CRP, lymphocyte count, D-dimer, troponin I, AST, LT, associated with severe COVID-19, serum albumin levels might help in prognostic risk stratification. Can I have the next slide, please? This is a meta-analysis of 90 cohort studies with acutely ill patients by Vincent showed that for each gram decline in serum albumin, there was a significant rise in the odds of mortality by 137%, morbidity by 87%, and prolonged hospital stay by 71%. So basically, studies have shown there is an inverse ratio between serum albumin level and risk of developing venous thromboembolism. As I've told you, the low albumin will give rise to more thromboembolism. Next slide, please. And this is with relation to COVID patients, and they show that a higher albumin level on admission predicts better prognosis in patients with confirmed COVID-19. Study published in PLOS in March 21. The 181 patient retrospective data in US between March and July 2020. Outcomes were recorded in medical conditions such as VTE, ARDS, intensive care unit admissions, discharge with a new or higher home oxygen supplementation, and readmission within 90 days, in hospital mortality, and total adverse events. Can I have the next slide, please? 62% have had hypoalbuminemia, that is albumin level less than 3.3. Patients with high albumin level on admissions reported 72% decreased risk of developing VT for each 1 gram per deciliter increase in albumin, lower risk of developing ARDS, less likely of readmission to ICU within 90 days, and fewer total adverse effects. So serum albumin level during hospital admissions appear to be predictive biomarker in COVID-19 patients. Screening in initial stages can help to early identify the patients at risk for developing in-hospital complications. And it also helps in improving the optimization and preventing efforts in patients with higher albumin levels. Can I have the next slide, please? And this is another trial. This is a hypothesis for underlying pulmonary capillary leakage. 174 COVID-19 patients with respiratory syndromes, 92 admitted to the intermediate medicine ward, and 82 to the intensive care unit at, this is Italian study. The main finding of this study was that hypoalbuminemia frequently found in patients with COVID-19 is linked to the degree of respiratory impairment, with lower serum levels in those with lower PaO2 to FiO2 ratio and higher CXS score. In addition, patients with serum albumin levels less than 24 grams per liter developed a higher in-hospital mortality. The patients admitted to ICU presented with worse albuminemia as compared to those admitted to the intensive medical wards, and this is accompanied by worse respiratory impairment and a higher mortality rate. So this might be serve as a severity marker in epithelial and endothelial damage in patients with COVID-19. Before I proceed to next slides, can I ask Dr. Gupta, we have been discussing both ARDS and septic shock, capillary leakage, etc. in COVID-19 patients. And COVID-19 patients, we had that infamous thing called a cytokine storm. But other than hypoxemia, the trials which have been there, successful trials, they've all targeted only hypoxemia. What do you feel is in your patients, how do you feel, how many of them actually died of ARDS and its complications, and how many died of pure cytokine storm in the form of septic shock or sort of non-septic cytokine storm shock? What is your take? Do you feel that most of the patients that died of ARDS, or you feel that many of these patients were also having some severe shock and they died of that?
So I would still say that ARDS was just a byproduct of cytokine storm, but patients who presented in an very early in the disease, let's say day 1, day 2, and severe ARDS, right? They actually did not make it, and they never could mount a pure cytokine storm scenario. But patients who still were on BiPAP or HFNC with moderate ARDS, and then eventually landing on a ventilator on day 7, day 8, they did have a very severe cytokine storm at that given point of time. So the ratio would be more or less like 30-40% patients who are very early in the disease, let's say day 2, day 3, and they did not survive, but purely ARDS, they were not landing to a cytokine scenario. My other take on the use of albumin, and this is not for hypoxemia, what we realized is that if the patients were having AKI to start with, and that was not bad AKI, it was not an oliguric or an anuric AKI, you do your initial fluid resuscitation, addition of albumin did help in resolution of AKI to a certain extent. I don't know if there is any relation to it or not, but this was what we experienced, that patients where the AKI, the creatinine, used to be stuck at 1.9, 2.1, although they were producing good urine, but the numbers were not getting better. Addition of albumin did help in resolution of AKI in a decent number of patients. Is there a relation to it or not? Very difficult to say, but this was the personal experience that I had.
So were this in the patients who had admitted early and went into a sort of septic shock AKI, or those patients who have been for ICU for more than 7 days, already sort of underfed, having low albumin level for quite some time, and then going into sort of septic shock, ARDS, and then AKI? Who were the group of, which group of the patients benefited with albumin?
I would say the early group benefited more. Once the patients landed up to septic shock scenario, things didn't work well. It was the early phase. If the patients are going to that extent, addition of albumin, as in you just added albumin at that given point of time, if the patients are in septic shock, multi-organ failure, the experience wasn't very welcoming.
So what you tell is that pure COVID-19 before the onset of secondary bacterial infections.
Yes.
At that point of time, if we intervene with albumin, then we might get better results. Let's say
this is what I felt, that yes, the patients did better if they were being given a decent amount of albumin. Again, as I said, I'm not targeting a number. I'm not looking at that I want to make the albumin level as 3.5. No, that was not the scenario.
Okay. Now, Dr. Gopal, you told us something about the Glycocalyx thing, that possibly that is related to hypoalbuminemia that gets damaged and caught surfacing. So would you also subscribe to Dr. Gupta's opinion that if we really want to act early, give them albumin, I mean upfront albumin, and so that they never progress into that hypoalbuminic state. So we don't measure albumins at all. All patients with COVID-19, severe COVID-19 who are in risk, first 2 days we give them supplementation with albumin or resuscitation with albumin, whatever we want to call us. Do you subscribe to this, or you have got different opinions?
You said something very important at Bandapade when you opened the session. We said we are not very clear about the cause-effect relationship of hypoalbuminemia and albumin administration or correcting the albumin. And Sachin very clearly said he's not targeting a number. But one thing I completely agree with Dr. Sachin, with Dr. Rajesh also, Dr. Mishra also said, earlier the better. If the patients are presenting, this answers both the questions that you asked to Dr. Sachin and me. If the patients are presenting in the early phase of COVID with moderate hypoxia, aka some other organ dysfunction, and it seems that if you could get the balance of intravascular versus extravascular volume, one of the instruments is albumin there. By using it, you could probably save them. But if they are past that, they are presenting late, they're already in cytokine storm, or God forbid in sepsis, then it's too late. Nothing will help them. They have to recover by themselves, or they have to change the nature's pathway. So in essence, yes, I agree with Sachin that albumin did help in staving off multi-organ dysfunction, especially PF ratio, and now AK is added from Sachin's experience to this. And there seems to be some role of giving albumin, and I would continue to do so. Early is the key word.
Dr. Mishra, you act as a super consultant in critical care in university. So many people, not only the patients you directly treat, but I know many of your intensivists, they ask for your advice and go by your guidance that how to treat their patients. So what is your advice to them? Do you advise them all COVID patients, they're given some sort of albumin resuscitation initially, first 48 hours, those serious COVID patients, of course, or you feel that we wait, we look for the markers, and then we intervene?
Honestly speaking, I'm not a very pro or anti. I take a very balanced step because there are two aspects of albumin which still we are theoretical. One is to maintain oncotic pressure, try to improve oncotic pressure, try to have more of the intravascular volume with maintaining oncotic pressure, avoiding the leak. And one of the concept long back it came when you in ARDS patients who are not very critical, like mild to moderate, combination of albumin and Lasix may help in improving the lung injury, because you are trying to take out the water, all the intrapulmonary or extravascular lung water, and that's why you are keeping your patient dry, improving PF ratio. What Dr. Gopal said, I do agree. So there are small clinical experience and studies where in critically ill patient, particularly patient has got ARDS, have tried to give albumin along with diuretic, maintaining oncotic pressure. But as I said, that it's a science of evolution. We have to go toward the safety, looking toward the safety of albumin. You have to just remember, at the end, albumin is a foreign body. it is antigenic. We are not very, the one aspect which always concerns me about it, because so far we have not a single study, apart from the liver dysfunction or cirrhotic liver where albumin has a role. Other places it's like ups and down, you get some benefit and you get some harm also. So when you are using albumin, every time you have to ask yourself that you are benefiting patient, or because we all are clinicians, we are all scientists, we do evidence-based practice. You will not get evidence for everything. So neither I am very hard of not giving, neither I am very soft in giving everybody. We go by balance. Like say for example, if I get a patient, irrespective of condition, he is stable, his blood pressure parameters fine, just needing oxygen, maybe moderate, he needs other antibiotic, but no other changes. So I will not push albumin to that patient, presuming that he may worsen, because we do not have a denominator that this patient will worsen, this person will not worsen. But if I get a patient who shows, apart from lung injury, any other sign of organ dysfunction, markers going up, not responding to initial management, initial resuscitation, or there is a clinical deterioration, or there is a sign of fluctuation in blood pressure. So, I mean, these are the patients which needs hour by hour, minute by minute assessment based on your clinical judgment, based on your biochemistry, based on your hemodynamic status, oxygen status, and then you give. So probably we do not give a blanket order that you give albumin to everybody, but probably we do not say also not to give albumin. But I am little I take a middle path. I assess and advise, but I'm not too much towards albumin, either pro or against. I like kind of neutral towards albumin, and I go case by case.
You're muted.
Dr. Upadhyay, you are muted.
Oh, sorry. Yeah. So you remain albumin neutral. I'll ask you two point blank questions. A patient comes with a COVID patient, first 2 days comes with ARDS, and the patient has got a low albumin. Do you prescribe albumin or not?
No, never.
Not
for the number. Not for the number. Irrespective of the condition, if you talk about the COVID or any other condition, if albumin is low, somebody is coming, forget about COVID, any other, except I said, except cirrhosis, liver, ascites is there, where we are training is a different scenario. Otherwise, irrespective of the condition, we never give albumin to elevate, because there is one more theory or one more concept. If you give too much of albumin in a patient, particularly who is having acute inflammatory marker, apart from injury, it may happen that there can be a negative feedback for albumin synthesis. So you have to be very, very careful when you are giving too much of albumin to a patient where hypoalbuminemia is condition. But a lot of our surgeon friends, lot of people who are like very particular about, now they don't see albumin level, for wound healing they will give albumin. So many indication people are doing. Like we are also experienced, but somehow I find that overuse of albumin, we have to be very careful. We have to be careful in using in appropriate patient, but not with the number. We need to know why we are giving albumin. There are certain evidence not there. You can physiologically see the parameters, look for that. Suppose what difference you made. Suppose somebody albumin was 1.5, you gave 60 gram albumin, his albumin now came 2.5. This example I am giving. Simultaneously, you see that patient clinical condition where is going. If you made the albumin level 2.5 next day, or your patient is clinically deteriorating, you have to be careful about this. So when it comes to replacement of albumin, one patient, they are very, you have to give, you don't have to measure, because you know there is huge loss of albumin and body cannot compensate. So there are conditions where albumin loss is more. One is one among them where albumin you have to use. So I said that case by case you have to go. COVID probably do not fall in the category where you start giving albumin to everybody. You have to be categoric about your patient category.
Thank you. Okay, so let's go to the slides once more. Ms. Singh, can I have the next set of slides? So this is another one, that oxidized albumin predicts severity of COVID-19 in hospitalized patient. As a trial, this Thiol measurement in admission is promising tool to predict ICU admissions in COVID-19 patients, where IL-6 and calprotectin measurements effectively predict mortality. Measured waste biomarkers, thiol, advanced oxidation protein products, ischemia modified albumin, inflammatory biomarkers, and cellular activation biomarkers in plasma in admission. Thiol concentration decreased while IMA, IL-6, calprotectin, and PSAP increased, with the disease severity in COVID-19 patients were associated with increased O2 needs and ICU admission. The problem with markers is that COVID has got almost 8 to 10 markers which actually predict what's outcome in COVID. But none of them have come with a good study to show that once we start reacting on basis of that marker, we can change the course of the illness, except for hypoxemia. So all the trials we ultimately do in COVID is related to hypoxemia, be it steroids, be it baricitinib, and whatever it is, remdesivir. So can I go to the next slide, please? For acute patients, acute resuscitation of adults with COVID-19 and shock, surviving sepsis campaign guidelines suggest albumin when crystalloids alone are not sufficient, independent of serum albumin levels. Restrictive fluid management strategies in COVID-19 and acute ARDS include albumin replacement in hypoalbuminic patients. Use of albumin solutions increase low serum albumin and reduce D-dimer levels, suggesting therapeutic potential of albumin in COVID-19 patients, and nutritional support therapy to correct serum albumin may improve patients' outcome. So I'll go to Dr. Gupta. Dr. Gupta is a stickler for evidence-based medicine. So what do you feel right now the evidence tells us about the use of albumin, as I've asked, in COVID-19 and shock? I mean, does it go favor the general trend of the evidence? Does it favor use of albumin in most of the patients in COVID-19 initial first 2 days in ARDS or in shock, or the evidence is still sort of
so the evidence is still, still gray. I would say you don't have a hardcore evidence of, as Dr. Mishra rightly said, it should not be a blanket rule that COVID-19 diagnosed, the prescription should have albumin. No, that's not the scenario. Severe COVID with hypoxemia, yes, because see what we, this is not that typical ARDS where by day 3, day 4, they start flooding the lungs by fluid resuscitation. And then you plan, can we decongest these patients? If you remember, a very early study had come, the FACT study, where they said by day 3, you should have an equibalence, right? Your intake output should be fine because you don't want these patients to become more hypoxemic. Unluckily, this doesn't hold true much in COVID. They are hypoxemic, they are worsening even by day 1, day 2. And what we felt is, and this is there in COVID, that if you're just giving diuretic without albumin, right, to decongest, they will develop AKI. They are very fast to develop AKI. When you combine albumin along with the diuretic, it helps in basically acting of the diuretic, because if, let's say, if you're giving diuretic, you put 40 mg Lasix furosemide in let's say 100 ml of 20% albumin and continue it over 5 hours or 10 hours, the distal convoluted tubule action of the diuretic increases, and then you achieve a good diuresis without causing an after effect of an AKI. So I would still say there is no hardcore evidence as in yes, you have to give albumin. But by experience, my personal experience, if the patient is of severe ARDS with COVID very early in the disease, I do give albumin. At least I would say for first 48 hours, my 40 grams albumin is generally the prescription that I prefer. I feel more comfortable that my fluid balance has been managed, and I try to keep them equivalent from the first 24 hours. I'm not waiting for 72 hours and then think of what is the fluid balance. They don't tolerate that much.
Thank you. Before we go into the therapeutic part of the albumin, that is albumin supplementation, I'd like to sort of sum up that what we have progressed in our discussion. One thing we have discussed, that albumin may be low in COVID patients, and it may be related to many of the adverse outcomes in COVID patients. That's fine. The question of that whether we can change by changing the albumin status, that remains undecided. But for that matter, the panel has right now discussed maybe in the first days, early COVID, not when the patient has gone into multiple superadded infections. At that point of time, if the patient is maybe in ARDS or in shock, at that point of some amount of albumin resuscitation might be helpful, particularly if the patient has got low albumin. And the panel also feels that the albumin might be related to this glycocalyx leak and etc. So it might have a wider role in COVID patients who have got inflammatory response, or maybe cytokine storm, whatever we want to call it, in these patients. And third is that there is no hard and fast rule that all COVID patients should be given albumin, but clinical judgment to see whether the patient is benefit, whether the patient seems to be volume overloaded, too much of assessing, whether it might be combined with Lasix or maybe hypoalbuminemia. In these cases, the intensivist may decide according to the patient's profile in intervening and giving albumin supplementation. The albumin supplementation usually is given right now, as I understand, is 20% albumin, but there is some scope maybe also for 4% albumin in the early stage of disease when the patient might be in shock. So is that okay, or we have anything else right now?
I think that's very well summarized, Dr. Bandyopadhyay.
And about the last, we'll ask you, Dr. Gopal, about this supplementation. This one thing I wondered that we do have intravenous albumin, no questions about that. You can give 4%, 20%. But people also try to supplement hypoalbuminic patients with albumin. So
Right.
there have been some albumins in the market. My understanding of physiology is that albumin is not absorbed as albumin. It is again broken down into sort of peptides and etc. taken from the gut, and the albumin is then synthesized. So do you feel that this albumin supplementation in the form of preformed albumin or maybe egg flips, egg whites, does it have any advantage over routine protein supplementation in a patient? I mean,
You're talking about the enteral supplementation?
Enteral supplementation. So what do you think your supplementation is? I'll ask you specifically two questions. Do you feel that this enteric albumin supplementations in the form of tinned albumin preparations or egg flips, does it have any advantage in correcting hypoalbuminemia than routine or protein supplementations are given to the patients? And second question is for parenteral, do you prefer still the 20% or the 4%?
Right. For the first question, I mean, let me plead guilty that we have used this tinned albumin in various patients, but we have especially used it in those patients where the IV albumin, I won't use the word supplementation, the IV albumin administration was proving to be very expensive. And we are also worried about the capillary leak that Dr. Rajesh Mishra was talking about, along with pitch albumin leak. In these two circumstances, we have given oral or enteral supplementation of albumin powders. But I take your point that albumin may not get absorbed as albumin. It may actually give the substrate to synthesize other proteins that are necessary in the body through, if the liver and other protein metabolism is working properly. So supplementation of albumin, because albumin is low, may not work. Way back in 2001, John Louis Vincent did a 99 study meta-analysis where he clearly proved that low albumin levels are a good predictors of mortality and morbidity, but supplementing albumin may not change that mortality and morbidity. So I still go by that belief. Coming to the second question of 20% or 4%, I don't use 4% at all. I use 20% as a slow infusion over however many hours we calculate. For example, in some cases we give across. The second hat I wear, I'm also I have been a liver transplant anesthesiologist and intensivist for quite some time, where we have used albumin very liberally. From there, we learned some lessons that quick administration of albumin may not help the patient except in ascitic tap. So in other conditions where patient oncotic pressures are low, all these patients are hypoalbuminemic liver patients. So we have learned the art of giving it slowly, but at the same time keeping a very rigid view on intravascular volumes. For example, if you extrapolate these lessons into COVID, we all know that when COVID presents, it may present as an L type or a H type. When it presents as L type only with the peripheral shadows, where the compliance of lung is still good, and patient is hypoalbumic, probably that is a window of opportunity where you can give albumin and stop him from deteriorating further. It may not work in everyone. This is worth a trial. But if the patient has self-induced lung injury or the H type, he went into the florid ARDS that we see in sepsis as well, giving albumin there may not help at all. In either case, if I want to give albumin, one, I would strongly recommend you give it as a slow infusion. Two, I also recommend, like Sachin said some time ago, to piggyback with furosemide along with it, so that the intravascular volume control is within our hands. And the PAC trial, as again Dr. Gupta said some time ago, has proved that if you flood the lungs, a damaged lungs, a ventilated lung, which is having ventilator-associated lung injury also, beyond 72 hours, if you flood the lungs, the outcome is going to be very negative.
Thank you. So we have almost come to our last part of our this discussion. I'd ask one last question to Dr. Mishra. This is, we have not asked that how much. Our question is how much. We have started supplementing the albumin as per your guidance, maybe in CLD patients, or maybe in a very selective patients with a RD, RDS, or shock, where we are supplementing. What should be our target? That we go by some albumin level, that we should achieve the level and stop, or do we go by, say, 3-day course? We give a 3-day or 5-day course and then stop, or any other parameter? How do you decide how much albumin to give in?
So again, I will go by case. If it is I'm dealing with cirrhotic liver patient, then there is a very definite recommendation that you try to maintain at least 2.8 or above the albumin level, and you replace and you give it slow infusion. Same way applies for the transplant patient that we are dealing with. But when it comes dealing with ARDS, like somebody coming to me shocked, so there are very clear recommendations that you are giving to supplement a tide over the dilution which you have done. So like suppose you give 2 liters of the normal saline as a crystallite, you give around 100 ml or 20% albumin to tide over that condition and see that how patient responds. These are the tide over measures. As far as supplementation is concerned, again for ARDS, we give albumin and see the response. Suppose I am using to tide over improve the hypoxemia, so I'll give around 100 ml or 200, maximum 200 ml of albumin over 10 hours with elastic, see the response. If that works, we'll see. But simultaneously, we check the albumin level. Suppose we are giving albumin, albumin start getting better, and it is like coming to the normal level of 3 and above. Then probably I will not try to give albumin more. So what I do, I will not try to maintain. And that is another sign that patient condition is getting worse, patient is getting better. So if you keep on giving albumin to this patient, you are doing 2 harm. You are doing financial harm. You are also have the potential to do harm due to albumin, because ultimately it is antigenic and albumin per se has the potential to cause lung injury. You have to vary. So all these factors have to keep in mind. We do not know that what is the exact value you have to maintain, but we do not go above the normal value, and we do not like wherever we do not have anything. We have a specified goal. Shock, we have a specified goal. RDS, we have a specified goal. Burns, we have a specified burns. You have to, because your albumin protein level demand is too high. You need at least 2.5 gram per kg. At least you try to give 30 or 40% as albumin, because doing that you will reduce the third space loss, you will reduce the extra water loss. That is proven. Here you may go up to even, sometimes we go up to like 3 or 4 or even up to 100 gram of albumin we have to give, depending upon the body weight and initial phase. So it is all, I cannot give you a formula that, okay, 100 ml all patient, 200 ml all patient. You have to measure, monitor, and go case by case, because we do not have evidence. So we are kind of trying to be play safe, not causing harm, trying to get maximum benefit of the albumin, and trying to be cost effective as well.
So we feel that this should be case by case. There is no definite measure of albumin to which we should correct, except for CLD patients. And
CLD burn and septic shock, where you have given more than 3 liters of the crystallite and still patient is not responding. They have enough evidence to support. Other place you have to go case by case.
Right. So that is the take right now. So that is almost we have done. So we have come with some definite, say conclusions from this discussion, lively discussion, and all the 3 panelists, they have given us their input. Any one of you would like to add something to what we have already discussed? Anything else you feel that we have not discussed?
I think a lot of take-home messages for me also, where to be prudent and where to be liberal. There is no evidence. I do agree. There is no evidence. But then unless you have
Dr. Gopal, I fully agree. We do not need to follow evidence in every case. That's why I said that COVID has also taught us that we do not believe only evidence. We need to believe science and physiology. That's why we need to know more and more about physiology. But as I said, that when we are following the physiology and science, we have some denominator to find the benefit versus harm. Whatever gadgets or whatever method we are using to save our patient, make our patient better. That's not the bottom line I want to say. So as I said, I'm not against anything. I'm not against against thing. I want to balance the thing every time, because at the end of the day, we are responsible and answerable whatever we say.
What I was about to just say as my concluding remark is, unless you have a hypothesis, somebody will not produce evidence on it. So my hypothesis is albumin is working at a microcalcial endothelial level, and that's where we are seeing the results if given early. I will leave it to the scientists to prove that.
Dr. Gupta,
we can plan if the plasmagen people agree. We can plan a study only on albumin and Lasix in mild to moderate ARDS and see the effect, how it works, and it will be a really good study because there are some evidence where it works. So if we can capitalize on based on the evidence and I mean make a substantial contribution, that may help a lot of patients.
Yeah,
Dr. Gupta, you have any last lines?
Yeah, I would just say that whether there is evidence or not, but clinical science should, rule everybody. And the personal experiences will do create the evidence. And I still feel that early albumin administration in a rightly selected patient, severe ARDS, does help, at least when we are looking at COVID. I'm not talking about general sepsis, general ARDS.
So with that, we come to our end of our discussion. I'll hand over to Ms. Singh for the conclusions. Thank you.
Thank you so much, Doctor. Now I would like to invite Anand sir for giving the Thanksgiving.
Good evening, Dr. Bandapandey, Dr. Gopal, Dr. Rajesh, and Dr. Sachin sir. It has been absolutely pleasure and delight to listen to all of you. Dr. Rajesh has mentioned whether Plasmagen is ready to take part in clinical trials. And absolutely, it will be a delight to be associated with you on if you wanted to do any clinical trials on albumin. We are always open for it. As Plasmagen Biosciences, I sincerely thank you for your contribution, your time, sir. Especially Dr. Gopal, I think he is still recovering from COVID and make it a point to come to the session. We have always wanted to meet you personally. I hopefully in the next 15-20 days and get a more clarity. I'll ensure that at least my members I will come and meet you. I sincerely thank you for your contribution, sir. And all the elite panelists as well as the attendees, I sincerely thank you and have a wonderful evening.